الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Poliomyelitis by Professor Mahmoud Hani Sulaiman. Composition of term: polio equal gray, myelus means marrow, myelitis inflammation of spinal cord. This picture was ordinary before 30 or 40 years ago. In my school, we have some of these girls and boys. Infectious agent poliovirus is an enterovirus type 1, 2, and 3 cause disease. Classification of poliovirus: family Picornaviridae, genera enteroviruses: polio, non-polio, entero, rhinovirus, influenza virus, aphthovirus, and cardiovirus. Clinical feature: majority of polio infections are either inapparent or present as non-specific febrile illness. Flaccid paralysis occurs only in less than 1% of poliovirus infection. Symptoms of minor illness include fever, malaise, headache, nausea, vomiting. If disease progresses to major illness, severe muscle pain and stiffness of neck, back with flaccid paralysis may occur. Most character of polio paralysis is its asymmetric distribution, which affects some muscle groups while sparing others. Fever and muscle pain present at onset with maximum extent of paralysis usually reached in 4 days. Progression of paralysis almost invariable stops when patient becomes afebrile. Site of paralysis depends upon location of nerve cell destruction in spinal cord or brain stem. Proximal muscles of extremities tend to be more involved than distal. The legs are more often affected than the arms. Paralysis of the respiratory swallowing muscle is life-threatening. After 60 days, degree of existing paralysis is likely to be permanent. Sensory loss is very rare, and its occurrence strongly suggests some other diagnosis as Guillain-Barré syndrome. Sensory loss is very rare. Post-Polio Syndrome equal infrequent recurrence of muscle weakness that may occur many years after initial infection. It is thought to be due to progressive dysfunction and loss of motor neurons that compensated for neurons lost during original infection, not to persistent or reactivated poliovirus infection. Vaccine-associated paralytic polio, VAPP, is a very rare complication in recipients of oral polio vaccine, OPV, or their contacts, with about 1 case per 2.4 million doses of vaccine. Risk is greater for first dose than subsequent doses, and is slightly greater for adults than children. Difference between poliomyelitis and Guillain-Barré syndrome: polio caused by virus, common among infants, often up to 5 years, acute just prior to paralysis, the fever. Hallmark finding is flaccid and asymmetrical paralysis. In Guillain-Barré, it is flaccid and symmetrical paralysis. Course starts descending from trunk and moves distally down. The Guillain-Barré ascending, lower limbs first, followed by upper limbs. Cranial nerve involvement usually uncommon in polio. In Guillain-Barré, usually common. 7th and 9th nerves. Sensory deficit absent in polio, present in Guillain-Barré. and the other differences. You may print this table. Method of diagnosis. Clinical history including vaccine of case and household contacts and recent travel to any endemic area is very important. Diagnosis by isolation of virus from CSF feces or oropharyngeal secretions. This is important. It is present in oropharyngeal secretions. This is why covering mouth and nose during coughing and sneezing and so on for contacts or cases is very important. Two separate fecal specimens at least 24 hours apart and in 14 days of onset of symptoms give best chance of diagnosis. CSF with mild increase in protein and lymphocytosis. Reference lab Advaxera can also differentiate between wild type and vaccine associated strains. Incubation period from 3 to 35 days with 7 to 14 days for paralytic cases. Epidemiology of polio continued. 3 types, type 1, 2, 3. 1 mostly causes outbreaks, 2 easiest to eradicate, 3 often last to be eradicated. Highly contagious, usually infects 100% of all susceptibles. Occurs worldwide and is seasonal in apparent infection ratio, 200 cases for each 1 apparent case. Even some authors said it is 1,000 for each case. So when a case is detected, we have at least to immunize, to vaccinate 200 persons around it. Epidemiology. Prior to vaccination, polio occurred worldwide since Global Polio Eradication Initiative, which began in 1988. These countries declared free. Americans in 1994, Western Pacific 2000, and Europe in 2002. Polio cases decreased from 350,000 in 125 countries during 1988 to just 480 reported cases only in 10 polio endemic countries in 2001. By 2003, 6 countries were still reporting new polio cases: India, Niger, Pakistan, Afghanistan, Egypt, and Nigeria. Now Egypt is free. Epidemiology continued. In endemic areas, cases of polio occur both sporadically and in epidemics. In temperate climates increase during late summer and autumn. In tropical countries, a seasonal peak in rainy season due to fly increasing. In countries where polio eradicated, importation through non-vaccinated individuals remains a threat. Polio remains a predominant childhood illness, with 90% of cases in children less than 5 years. We're still in epidemiology. Reservoir: only humans, does not survive long in environment, no long-term carrier state, survival outside human very brief. Polio eradication in Egypt. Egypt succeeded in interrupting wild poliovirus circulation. Last confirmed polio case in 3 May 2004. However, Egypt experienced repeated wild poliovirus importations detected by environmental surveillance. In 2013, an emergency multi-country response, including Egypt, was conducted to contain Middle East outbreak. A field investigation and active search for paralytic cases conducted. Frequency of environmental sampling was increased twice per month and increased surveillance of acute flaccid paralysis. Routine immunization found efficient. Coverage for oral polio vaccine doses is more than 95%, and the other lines describing these efforts. I think this is a very obvious picture. Here we see a man in the time of Pharaohs affected with polio. It is endemic, was endemic in Egypt and now eliminated. Number of confirmed cases of polio 2002 till 2006 as of November 2006. Here is Egypt. The last case was in 2004. Non-Egyptian children up to 15 years from endemic countries and living in Cairo vaccinated in February, March, and April 2013. This is continuous efforts to ensure that polio will not recur to Egypt. This in trial not to import polio from outside. These are the efforts. Please read it. You can print it and read it. Reservoir, humans, mode of transmission, very important. Wild polio virus spreads through feces and saliva. Again, it is found in the oropharynx. It is primarily transmitted through fecal-oral spread and important where sanitation is poor. OPV virus can be shed in feces for 6 weeks, and this may lead to infection in unvaccinated contacts. Yep, unvaccinated household contacts of a case should be vaccinated at the same time, stressing importance of hand washing for parents following nappy changing and disposal is very important. Period of communicability, very important. The risk of transmission of infection is greatest for 7 to 10 days prior and 7 to 10 days following onset of symptoms. Virus persists in pharynx for about 1 week. Again, in the oropharynx, it is very important, and in feces for up to 6 weeks or longer in immunosuppressed. Transmission of virus is possible for as long as virus excreted. Susceptibility and resistance. All non-immune people are susceptible to infection. After infection from both clinically and recognizable and in apparent infections, type-specific lifelong immunity occurs. Reinfection rare, but can occur if infected with poliovirus of a different type. Vaccine efficacy of OPV and inactivated polio vaccine IPV after primary course equals 95% and thought to be lifelong. Both vaccines protect against all 3 types of polio. Infants born of immune mothers have transient passive immunity. Preventive measures. Universal vaccination in early childhood is the most effective means of preventing the disease and eradicating it. Catch-up immunization is recommended for unimmunized or partially immunized adults at risk of exposure and those traveling to endemic areas, health care workers in possible contact with polio cases. So health care workers. So the transmission may be occupational from the patient to the healthcare workers. Immunization as IM, IPV or OPV under API polio immunization consists of primary course of OPV as 2 drops orally at posterior tongue at 2, 4, 6 months with booster at 4 years. IPV for individuals with immunosuppression from disease or chemotherapy and for their siblings and household contacts. Both IPV and OPV give mucosal and humoral protection. However, IPV produces considerably lower levels of intestinal immunity than OPV. Preventive measures continued. Due to successful elimination of polio in most regions and increased concern with OPV of vaccine-associated paralytic polio, many industrialized countries changed to IPV alone for routine immunization. OPV is still recommended in developing countries because of, this is why it is still used in developing countries, higher risk of exposure to wild polio virus, low cost of vaccine, ease of its giving, its excellent capacity to provide population level immunity, herd immunity. This is the differences between IPV and OPV. Please print this screen and study it. This is the schedule for obligatory vaccination in Egypt. Please print it, study it, and put it in your office, in your hospital, to do it in the clinic. Control of case. There is no specific treatment against polio virus. Case require expert supervision and may need ventilation support. Early physiotherapy may increase level of function and decrease risk of physical deformities due to paralytic polio. Enteric precautions should be initiated in hospital settings. These are often of little benefit in household setting as susceptible contacts are likely to be exposed prior to diagnosis. Terminal disinfection is required for all other potentially contaminated items. Control of contacts, vaccination of families and other close contact recommended but may not contribute to immediate control due to susceptible contacts infected when first case is recognized. Active case finding, especially among children, ensures early detection of related cases, facilitates control of environment in communities with modern sewerage system. Feces and urine can be disposed into system without preliminary disinfection. Cases and carers advised on importance of strict hand washing, covering mouth. It is found in the oropharynx. Covering mouth when coughing, sneezing into disposable tissue, and appropriate cleaning or disposal of contaminated objects. Outbreak measures. In countries where polio eradicated, a single case of polio is considered a public health emergency and MOH must be notified immediately. MOH investigate to determine whether patient disease represents an endogenous, imported, or vaccine-associated paralysis. If believed to be vaccine-associated, obtain details of vaccine history, batch number, virus type, severity, and persistence of residual paralysis 60 days after onset. There is a special list for doing this. The MOH do this, and the MOH tell the WHO about these cases. Supervise all appropriate case and contact control measures as outlined above. What is the difference between elimination and eradication? Eradication complete cessation of transmission of infectious agent. Smallpox is the only example where eradication achieved control equal decreased transmission, so it is not a public health problem. Control needs ongoing preventive measures and consequently continued expenditure along with efficient surveillance system to give early warning of increased level of transmission. Elimination equals either a regional eradication, say from a country or continent, or of disease to zero without total removal of infectious agent from environment. This what happened with polio. Disease occurrence zero without total removal of infectious agent from environment. So the environment, we still observe, we still do surveillance for the environment. Eradication strategies which was done for polio: high-level national commitment, administration of polio vaccine, routine, non-governmental, and mopping up AFP surveillance acute flaccid paralysis surveillance. وفي النهاية لا أجد إلا أن أقول الحمد لله رب العالمين و thank you for your good listening.